All right, so I'm Dr. Deva Boone from the Southwest Parathyroid Center, and today we're continuing with the parathyroid education course, and we're talking about life after parathyroid surgery. So I'm going to talk about the weeks, months, years after parathyroid surgery, go over the most common issues people have, the most common questions. If you have more questions, please put them in the comments, and I will try to get to as many as I can after we go over kind of the slides that I have. So I have some slides so we can make sure I cover everything. Okay, so let's get going. I'm gonna put some slides up. Okay. All right, so should be able to see this now. Okay, so life after parathyroid surgery. Everybody obviously is a little bit different, right? So I can't always predict exactly how you are going to react after parathyroid surgery, but there are some constants and there are some things that I'm always kind of thinking about and looking out for, and I want to cover those so you understand kind of what we're going to expect after parathyroid surgery. Okay, so the big thing that people usually want to know first is, am I cured? And when will I feel better? And those are kind of my big goals too, is to get you cured and get you feeling better. When you see a surgeon, a lot of times what they're really focused on is getting you cured. They want to get the parathyroid tumor out. They're often not as focused on your symptoms. They really want to fix that problem of the parathyroid tumor. But a lot of times patients are really focused on when those symptoms are going to get better. So I'm going to go over both how you know you're cured and when you might feel better. And that's actually a very difficult question to answer because everybody is so different. Okay, but the first goal is to get you cured. And we do that really by getting a normal calcium and PTH. That's the goal. If you've been diagnosed with primary hyperparathyroidism and you're having surgery, then most likely you've got high calcium or a high PTH level, and we want to get those back to normal. That's the number one goal. Next is I want to get your symptoms better. So I do want you feeling better, not just having normal labs. I want you to actually notice that there's been an improvement. And then I also want to improve your health overall. So part of the reason that we operate is not just to get you feeling better, but also to protect your bones, protect your kidneys, protect your heart, get your blood pressure under control. All of those things are also part of the goals. For a surgeon, again, that main part is going to be getting those labs back to normal. Okay. All right. Now, I want everybody to kind of think of this in a certain way. When patients are really focused on the operation and they're really focused on getting better, a lot of times it all gets pushed together in your mind, that you've had surgery and recovery, and it's all kind of this one big event, and your life is going to change as a result of this. But surgery is an event. Surgery is this one big event. Recovery, on the other hand, is a process. So when you're thinking about it, just remember this. Surgery is this one event that you're going to have, but getting better, feeling better, all of that is a much more long-term process that your body has to go through. So I can take out the tumor and fix you in half an hour, but you're not fixed. Your body still has to recover. Your body still has to adjust, and all of those little symptom and health improvements that we're going to see are not immediate. It's not an event. It is definitely a process. All right. So the first few days, what do you expect in those first few days? Well, normal will be some neck soreness, right? So you did have an operation. You're going to have a bit of soreness, both from the actual incision and from the tube or airway mask that was used during your procedure. So you're going to have a little bit of soreness from that. That's normal. you're probably gonna have a little bit of fatigue. So when you have surgery, right, your body has to work through that. Even a short operation, you're getting some anesthesia. It is a stress on your body, not just from the anesthesia, just from having somebody cut into you and do something to your body. That is a stressor, and that's going to cause a little bit of fatigue in those first few days. Some swallowing discomfort, totally normal. This is because when we're operating, we're actually back there around your esophagus. So it's not unusual to kind of feel that. Might be partly from the endotracheal tube, but partly just because we're right next to the esophagus. The tissues are going to be a little bit irritated, and you're going to feel that when you're swallowing. And finally, some mild hoarseness. This is different from what I talked about where you can have a nerve injury during surgery. This is not a nerve injury. This is just soreness and the hoarseness from having an endotracheal tube, from having somebody mess around with the muscles in your neck and move things around. A kind of mild hoarseness, especially the first few days, especially if you're having surgery in Arizona where the air is very dry. That kind of soreness, that kind of hoarseness is very normal, and it tends to get better in a couple of days. Numbness and tingling, pretty normal because this is what happens when your calcium level drops. So this is the number one symptom, first symptom that you usually feel. It's things like numbness and tingling in your fingertips or around your mouth. I go over this with patients. I say, look, if you get that, you take more calcium. Typically that's going to start within a couple of days after surgery and you might feel it for a few days. It starts to get better within the first week or two. But this is kind of a normal thing to expect anyway, and know that you just need to take a little bit more calcium if that occurs. Okay, so this is my nice hand-drawn graph, and I did this because I just want to go over, explain what's going on with your calcium and PTH levels and why they're a little bit wacky right after surgery. So I put this little normal range here in gray and showing the PTH and the calcium. So PTH, you'll remember from our talks about surgery, it drops immediately. Within an hour after surgery, your PTH has gone from the high end to usually down into the very low range. So way below, below normal into that suppressed range. And then over the course of a few days, 2 weeks, it goes back into the normal range. Your calcium, what's happening with your calcium is it drops a little bit slower. It doesn't drop right away. So you'll notice, people will ask me, right after surgery, did I check the calcium? I don't check it the day of surgery because it's not going to change. If your calcium's high before surgery, it's going to be high right after the operation. But over the next day or two, it's going to drop, and it's going to start dropping down. It'll pass through the normal range and it'll go a little bit low. And that's kind of expected in that first few days, is that your calcium might go a little too far down low because remember the PTH has gone really low. Your bones start taking up the calcium again and your calcium level drops. Now all of this does start to normalize because your other parathyroid glands, right, those normal glands, start to wake up, they start to make more hormone, the PTH starts to rise. PTH now is responding to the low calcium, right? So your parathyroid glands that are still there are going to react to the low calcium and start making too much. So the PTH might actually overshoot, and I tried to kind of draw this on here where the purple goes a little bit too high, and the calcium is still starting to rise from the PTH. But if you check your calcium and PTH levels too soon after surgery, they're going to look weird. So I usually discourage people from getting labs done a week after. Sometimes doctors will order this, say, get your labs done a week later. I discourage it because they're often kind of hard to interpret. You'll check the calcium, it's likely a little bit on the low end. The PTH may actually be really low, or it might start to be in the high range because it's reacting to the low calcium. And that kind of fluctuation will happen for the first couple of weeks. So typically I tell people to go by symptoms, not by the labs. If you're feeling like your calcium is low, take more calcium, and things will start to even out. And usually I don't like to check labs before about 4 weeks because that's when things really are stable. They often stabilize within a couple of weeks, but they still can be doing this wacky thing where the PTH is a little too low, the calcium's too low, then the PTH responds and it goes too high, and then the calcium starts to rise. You just see all these changes occurring. Really, you just want to make sure that you're taking enough calcium to alleviate your symptoms. And you don't worry too much about those labs at week 1, unless you're having significant issues. Okay. That's my graph. Okay. So in the weeks after surgery, right, this is when things are starting to stabilize a little bit more. What's normal at this point? All right. So healing inside is happening for a long time, much longer than you think. So when you have a little cut here, right, all you see is the incision where I went in. That's all you see. But inside, there's actually a lot of tissue area that has to heal. And tissue healing goes on for months, where the tissues are actively doing things to heal themselves and to get back to normal. You don't feel any of that. You don't realize it's happening, but it's going on for much longer than you think. And this is true for any injury, actually. This is kind of your tissues are healing for longer than you feel it, for longer than you realize before they kind of get stable again. But in the weeks after surgery, this is when a lot of that healing is occurring, and the tissues are going to be more firm. You're going to feel it's going to feel firm, hard, and maybe a little bit swollen. Oh, wait. Let me just check something. Okay. My Facebook seems to have frozen. I don't know if everybody else is. Okay, let me take a minute because it's not showing up on my screen, but should still be going. Okay. All right. So it's probably just my machine. Okay. that's fine if it is. All right. So, so firm around the incision, totally normal, expected. People sometimes freak out about this because it'll feel hard. You know, they'll feel it and they'll say, oh my God, it doesn't feel like the soft tissue around it. It feels like it's hard. That's normal. That's the tissues doing their thing. It's normal healing. Swallowing tightness. So when you swallow, you may feel like it's tighter in the weeks after surgery than it was initially. And that also is that internal healing. So as things are healing, they kind of tighten up, like scar tissue forms and it's tight. And then it starts to kind of contract, makes everything feel tight, and then it's going to loosen up. So in the further weeks and months after surgery, it's going to be looser, but feeling that tightness is normal. Now, it's not so tight that you can't swallow. So if you're actually having trouble swallowing, let your doctor know. That's not normal. But a little bit of feeling like it's tight or feeling like it's weird, totally normal in the weeks after surgery. Okay, having the incision be red or a bit lumpy, very normal. So the incision, right, it kind of closes up. Usually it kind of seals itself, like the skin will sort of reattach itself and completely seal up within about 24 to 48 hours. But again, lots of healing is occurring. That line will look more red in the first couple of weeks, and it might be a little bit lumpy. Like it won't feel like it's nice and flat. It'll feel like it's lumpy. It won't look particularly lumpy, but it'll often feel that way. Again, normal. You've got sutures in there that are healing, that are breaking down. All of that is going to get better. And usually by about 6 months out, it's hard to see this line. It'll kind of turn into a red line and then it'll start to fade and be like a white line. I try to put it into a crease. Most people will try to put it into a crease so that it kind of disappears 6 months to a year out. And this is when you might start to notice your symptoms improving. Now, everybody's a little bit different, and some people will feel much better in the days after surgery. Some people wake up and they feel amazing. That is not the average. The average person doesn't feel great that first day, might feel a bit better the second day because that calcium's starting to drop, the PTH has dropped, but then in the week after, it might feel a little bit more tired as the calcium drops too low. As you get symptoms of low calcium, you might actually feel worse in that first week. Week 2 and 3 is when most people are starting to feel the benefits of the operation. And it's not flicking a light switch, right? It's not like suddenly you have no fatigue. For most people, it is a gradual improvement that continues in the weeks and months after surgery. So if you ask most people at 2 weeks out, are you feeling any better? The average person may be feeling some benefits, but they've still got symptoms. They're still not feeling great. You got to give it more time. And sometimes it takes months, and it's not uncommon for it to take months for people to feel better, even though their labs are totally normal. Okay, so symptom improvement. As I said, everybody's different, but also every symptom is different. You don't get all the symptoms improving at once. They're usually on their own timelines. So bone pain is the one that gets better right away. This is the most satisfying for patients. If you've got bone pain in a specific area and it's been really bothersome, you may be the most satisfied right after surgery because it gets better immediately for a lot of people. It disappears. And that is extremely gratifying when that occurs. But it sometimes, in some cases, bone pain can return in the weeks after surgery. It does resolve again after that. As the bones are remodeling, though, you can sometimes feel it. But bone pain gets better right away. Okay. Fatigue, brain fog, usually in the first few weeks. This is also highly variable, but most people are starting to feel those improvements in those first few weeks, and then it does continue. And from talking to people, it seems like it's kind of a long, slow process. So the fatigue starts to improve, but 6 months later is when they really said, okay, yeah, it's good. And others are highly variable. So there are lots of other symptoms. It is extremely variable as to how they will react, when they'll get better. It's not uncommon for it to be months for something to get better. And I say all this not to dissuade you from having surgery, but just to, have you have the right expectations. Our goal is to get you feeling better. That's definitely the goal. And some people will feel better immediately. Others will not. And that's okay. That's okay. You're going to get there. You are healthier even with this tumor out, even if you don't feel it quite yet. Okay. So whatever that. All right. So post-op labs. So the labs that I am checking post-op, I'm checking three things primarily when I check post-op labs. So and I usually tell people to check them about 6 weeks. Anywhere from 4 to 8 weeks is fine, or later. It doesn't have to be exactly around then, but I don't want to take them too early, right? I don't check a week after. And I do want to check it within the first 2 months just to make sure that everything is going well and we don't need to adjust your calcium or vitamin D at all. So the post-op labs that I check the calcium, the PTH, and the vitamin D. And by about 4 to 6 weeks out, calcium should be within the normal range. Typically, the PTH should also be within the normal range, and the vitamin D, it varies as well. But if it started out close to normal, it's probably still in the normal range. It is helpful to see the vitamin D because sometimes the labs are not in normal range, and this is a common issue that I deal with. So when I check labs at 6 weeks, it's not uncommon for the labs to not be completely normal and for patients to kind of freak out because the PTH is still high. So if you look at these pre-op labs, pre-op calcium is 10.6, the pre-op PTH is 80, did an operation, took out a parathyroid tumor, and now the post-op calcium is 9.1, but the PTH is still 80. So the patient's thinking, wait, nothing changed. I'm not even cured. My PTH is still high. But the key here is that the calcium is very different. And we have to assess it the same way we did when we were diagnosing parathyroid disease, right? Which is to look at the calcium and the PTH together and see what is appropriate, figure out what is appropriate. For a 10.6, a PTH of 80 is totally inappropriate, right? It is way too high. It is diagnostic for primary hyperparathyroidism. If my calcium is 9.1, it's actually on the low end, and a PTH of 80 is totally appropriate. So at this point, this picture, this post-op picture, is consistent with secondary hyperparathyroidism. Not uncommon. Why? Because your body still needs a lot of calcium. If you have some bone loss, then your bones are taking up the calcium and you're not getting enough. So even though I'm still giving you, or you're still taking the post-op supplements for calcium and vitamin D, maybe you're just not getting enough. Your body needs more right now. And that's what the parathyroid glands are saying. The parathyroid glands that you have remaining are appropriately increasing their PTH because they're trying to get the calcium up. So what we need to do in this scenario is just stay on course. You are cured. That's the good thing. But now the calcium's a little too low and we just need to bring it up to get that PTH level to drop back down. Okay. Now, the months after surgery, what is happening? All right, so at this point, everything starts to soften up. So remember when you first had surgery, after the first weeks, it's firm. Things start to soften up. Things flatten out, they soften up. The incision, the scar is going to start to fade. It's going to start to lose that color, not be so lumpy. Symptoms are still improving at this point. And now we're going to see some of the positive health effects. So we don't see these immediately. If you've got osteoporosis, it doesn't bounce right back. You don't have normal bone density, a week after surgery, right? But in the years and months and years after, you're going to start to see improvements. Things like blood pressure and cardiac arrhythmias, all of those can start to improve in the months after. Kidney function, we do see improvements in kidney function, but not immediately. We're talking more like 3 to 6 months out is when we start to see that improvement in kidney function. If you had a drop in kidney function with primary hyperparathyroidism beforehand, then we'll start to see that improvement in the months after. Okay. After parathyroid surgery, so remember, the labs improve long before the symptoms improve. It can be disheartening to see that your labs look perfect, but you still have symptoms. It's really important to remember the labs are going to improve before the symptoms. Your labs will look great. I will email you and say everything looks perfect, and you might email me back and say, but I feel exactly the same. That's okay. That is pretty normal. It is going to get better. And the labs pretty much always will normalize before your symptoms go away. Can I fully explain that physiologically? No, because theoretically, you should feel better as soon as the labs are better. It just doesn't happen like that, unfortunately. Okay. So just to reiterate, the biggest thing, the most important thing to remember is that the operation is an event. It is something where we are getting you cured. A lot of times the surgeon may only be focused on that part and whether they've actually taken out the tumor and gotten your calcium back to normal. That's really what they want to see. That's their goal. The recovery is a process. It is not an event. It happens over a long period of time, and everyone will get there. You will get there, but it's not immediate. This is a process, and it's going to take some time. And a good way to think about it too is that your body was developing this parathyroid tumor likely for years before you had surgery. Most people don't show up the minute that they have a high calcium, right? Their body has to deal with this for years before we actually address it. And when that's the case, a lot of things have been going on. Your body has changed and adapted to that. It needs time to recover from that. Even though you take out the tumor immediately, your body has to recover and has to adjust to not having the parathyroid tumor there. So think of it like that. I think if you can think of of this recovery as a process, you'll do a lot better. And, kind of have an idea of what to expect, not expect everything to immediately bounce back and be totally normal. Okay. So, that's what I've got for the slides. Hopefully that gave you kind of an overview, explained what you're going to expect for the first months, weeks after surgery. After those first labs, when I get the labs around 6 weeks, if they are totally normal, then what I do is basically tell you to just get labs done as you normally would, with your regular doctors, so like annual labs. And if everything stays normal, as hopefully it will, then you don't need to come back to me. But you do want to follow your calcium long term. So over the years, you want to check your calcium level just as you normally would with regular labs. You want to make sure it stays normal. And if you have bone loss, I usually recommend getting a DEXA scan about 1.5 years or 2 years after surgery, because again, your bones aren't going to immediately bounce back. It is going to take some time for things to correct. Okay, so I want to answer some questions. Okay. All right, let me try to get to all of these. So I'm going to try to answer the questions in order, and hopefully get to everybody. All right, let me know if you have any issues with hearing me. I am recording this too, and this will be posted on YouTube probably within a few days as soon as I get to it. So that will be up there. But okay, let me answer some questions. So, okay. Mary says, I just had my second surgery. First, I got 3.5 removed. Second, a small bit of the half. I have 1 kidney, high calcium, and PTH. After second surgery, the calcium is 10.8 and the PTH is 11. So is that PTH? So if the PTH is in picograms per mil, then that's a very low PTH. If that is in the other units, then that's still a high PTH. So I'm not sure. It'd be helpful to know the units for that PTH. But if your PTH is 11 and the calcium is 10.8, that PTH level is very low. Suggests that maybe there's some other cause for the high calcium. So there's a few possibilities. One is if you are taking a lot of calcium. So if you're taking a ton of calcium and that's pushing the calcium up. If you're not on a ton of calcium, but the calcium is still 10.8, you may need to look into possible other causes for your high calcium. It's not impossible that you have something like a CASR mutation, which would be causing the high calcium level. So kind of a little bit of an odd situation to have the 3 operations, but I would possibly, you want to have a different, another assessment really, because if all you have left is half a parathyroid and you're only making a PTH that's low, then you want to look at other possibilities. Okay. All right. So, okay, Mary Ann says, I had surgery in September 2024. A little over a year later, I had improvement in the lumbar spine from osteoporosis to osteopenia. Forearm only improved by 0.1 and is still in the significantly osteoporotic score. Have you seen improvement in the forearm osteoporosis over time? Had 3.5 glands removed. This is tricky. So, talking about improvement in bone density is hard because it is so variable. Some people do, some people will notice significant improvements, others will not. For some people, it may just be that we stop further damage, and we're not going to actually get you better, but it's going to stop it from getting more damage. In other cases, we do see improvements, but the actual information on it is highly variable. And it's something like in the studies, you'll see like 10% improvement per year for the first 3 years. And we don't really have data after that. And the 10% is the 10% improvement in your numbers, but that's an average. Some people had zero improvement and some people had much higher improvement, or much better improvement. Have I seen improvement? Yes, you may still see improvement in that score on your forearm. Since you're in the significantly low range of -4.2, it's probably not a bad idea to think about some of the treatments, especially if you've had fractures with it. But if you haven't had any fractures and, if you're doing all of the other lifestyle interventions, then you may be okay. But at that point, at that -4, that's when I sort of start to think about some of those medications if you're not already on them. Okay. Dee Dee says thank you, and you're welcome. I'm happy to do these. Okay, Brenda says, I am 8 months out. First month, I felt great, then downhill. A lot of body pain. PTH is 46 and calcium is 8.9. Does this get better? So for Brenda, your calcium's actually a little bit on the low end, and that might actually be part of why you're not feeling great. I would probably try to get your calcium up into the mid-9s because most people do feel better with that. Remember, both low calcium and high calcium can make you feel unwell. So if your calcium level is only 8.9, then it would be a good idea to see if you can get that up with calcium supplements. And that might make you feel better. Okay. Felipe says, I'm the best. Thank you. Okay. And Brenda says lots of pain still. So if it's bone pain particularly, then definitely getting the calcium up will help. I would, for everybody, if you're taking calcium, you also want to be taking vitamin D. And if you're kind of dealing with low calcium and having to take a lot of calcium, then also taking magnesium is a good idea. Even if your magnesium level is in the normal range, magnesium does help with calcium absorption and calcium metabolism. So for Brenda, I would definitely recommend a little more calcium and vitamin D and magnesium, and possibly vitamin K too. It can't hurt. So I would try all of those. Okay. Barbara says, curious if there's a time frame for bone remodeling. It's so variable. She says, currently I have to take a PPI and I'm worried that I'm missing my window for bone improvement 1 year post-surgery. No, you haven't missed the window. The bone improvement occurs in the course of years. So for most people, we may see improvements at 1 year and then at 2 years, but you haven't missed any time frame. If you are taking the PPI, I assume you're kind of worried about calcium absorption maybe, because that's how PPIs can affect things. It can make it harder to absorb calcium carbonate. The way you get around that, the best way is to just take calcium citrate, because PPIs don't affect the absorption of calcium citrate. They do for calcium carbonate. Okay. Maggie says, thanks for the forum. Have you ever seen an adenoma pressed against a vocal cord causing paralysis? I was evaluated for primary hyperparathyroidism when the surgeon discovered I had a left vocal cord that was paralyzed. Ultrasound and cestam may be both negative, but surgeon thought she saw something on both. Okay, this is a tricky one, Maggie. So I've only seen this once. For the nerve, right? Because what it is that it's not really it's not pushed against the vocal cord. It's that it's pushed against the nerve. for almost all cases, the tumors, parathyroid tumors, are very soft and squishy, and they don't tend to really like push on to affect the nerve. They can be right next to the nerve, even if they're stuck to it. Even if an old tumor that's kind of stuck to the nerve, tends to not affect the function of the nerve. So the nerve still works, your voice still works. What can affect the nerve is a tumor that's invading it. This is more often thyroid cancer. So if you do see, if they saw a nodule on your thyroid ultrasound, for example, and on that side, and they saw a nodule on the back side and your voice was gone, we worry about thyroid cancer. That's the thing we worry about. Other people can just simply have a paralyzed vocal cord and we don't know why. It's not typical. It's very unusual. But I have had cases like that too, where it wasn't really clear why one of the vocal cords was paralyzed. And I did have one case where the tumor was very old and did seem to be invading the nerve around it. It was maybe parathyroid cancer. It's the one time where you kind of worry about that. Parathyroid cancer is so rare that it is very unlikely that that's what's going on, especially if they didn't see anything on the scan. Parathyroid cancers are typically not hard to see because they tend to be bigger and impressive. So it seems like this might be an incidental finding. Maybe you have a paralyzed vocal cord for some other reason. But could it be this? It'd just be very, very unlikely, not impossible, very unlikely for the parathyroid tumor to do that. Thyroid cancer, thyroid nodules, much more likely to do that. But yeah, okay. Amanda's just saying hi, hello. I'm glad everybody could join tonight. Okay. Mickey says, my PTH went to 17, but the calcium is still at 10.7 6 weeks post-op. Removed all calcium supplements. Is this normal? So the important thing here is to know what the vitamin D level is, because sometimes I have patients who are taking a lot of supplements before surgery and the vitamin D level is still high when I check their 6 week labs, and that can push the calcium up. And sometimes that will give you a high calcium still at 6 weeks because the vitamin D level is still high. So the first thing I'd want to know is, what is the vitamin D level? A PTH of 17 means that the parathyroid glands are not, they're partly suppressed, right? They are not likely to be the cause of the calcium of 10.7. So there's some other cause. Could it be vitamin D? Yes. Could it be that you need to be worked up for one of the genetic syndromes like FHH, which I mentioned earlier? That would be my next step, would be to really look at things there, see what is your vitamin D. If your vitamin D is not very high, look at your urine calcium. Do you have a very low 24-hour urine calcium? In that case, something like FHH might be likely. And with FHH, remember, it's familial hypocalciuric hypercalcemia. With this, your calcium level is not going to go back to normal after parathyroid surgery. It will remain high because you have a lifelong high calcium. That's part of the syndrome. But you have to kind of be worked up for that. So it requires a little bit more investigation. It's not exactly normal to still have a calcium of 10.7, but a PTH of 17 after surgery, and that requires investigation. Okay. Alice says, 5 years post-op, no working parathyroids, now have neuropathy. Calcium is 8.9. I assume you're being treated for hypoparathyroidism, and a lot of doctors will kind of keep the calcium on the lower range. You might feel better if the calcium level is a little bit higher. Hypoparathyroidism is a whole other topic, and there are other treatments for that. We do have now an injectable PTH if it's really causing a lot of symptoms, and you have no working parathyroids. Okay. Sherry says, my calcium was still on high end a month after surgery, so the calcium was stopped, but the tingling and numbness I get in my toes, calves, and fingers still happens, especially while sleeping. It comes and goes. I'm on vitamin B12 and vitamin D. Can't get calcium checked until June. Surgery was March 17th. My heart rate and palpitations stopped. No more racing heart. And the latter happened immediately after surgery. Great, that's good. Sometimes palpitations can actually get worse in the weeks after surgery as the calcium shifts. So it's good that it got better immediately. Sometimes it actually does get worse. But okay, so you're in an interesting position. So you say your calcium's on the high end, but you're getting those numbness and tingling symptoms. And sometimes people wonder, are they imagining it? And no. When your body's been used to a really high calcium level, it's not that weird for you to feel like your calcium is a little bit low, especially in the first few weeks, to feel like it's low, even though it's not actually low. So if you get your labs checked, your calcium will look normal, but you still feel those symptoms of low calcium. That's because your body has been used to that higher calcium and it's feeling the shift in calcium. And the other thing, Sherry, is I would want to know, if your calcium was on the high end, was that right after you had to take a lot of calcium for the symptoms? It would be helpful to know that. I don't know why you can't get labs again. I guess June is in a few weeks. So it would be good to get the labs checked again. But yeah, it's still normal to kind of get those feelings of low calcium, even though when we check it, your calcium level looks good. Because you're still having those shifts. Okay, Will says, I'm 1 year post-op from having the parathyroid gland removed. Everything is normal. How long do I have to check PTH? Every year, forever? Well, so it varies. For most people with classic labs, so if you had, before your operation, if you had high calcium and a high PTH level, or high calcium and a normal PTH level, and then you have surgery and your calcium level is now normal, I just recommend checking the calcium every year. I check the calcium PTH at 6 weeks, right? I want to make sure everything looks good there. But after that, if your calcium is staying in normal range, you don't necessarily have to check the PTH. If it goes out of range, then check the calcium and PTH together. So you don't have to check the PTH forever. For most people, their disease was very easy to see because their calcium went high. So if your calcium goes high again, that's when you check the PTH. For somebody with normal calcemic disease, so if you had normal calcium levels but your PTH was really high, that's when I recommend following that PTH, because that was the clue for the diagnosis, was just the high PTH. Okay. Lisa says, if blood calcium levels are normal with the high PTH pre-surgery and you're hyperparathyroid, is testing them as a pair still part of the post-op testing? Oh, absolutely. Absolutely. Because you're still looking for that relationship. You're still looking to make sure that whatever you have is appropriate. And remember, I showed you the case where, the calcium was suddenly, like in the 9.1 range post-op at 6 weeks post-op, and the PTH was high. Well, that was appropriate. If you've been diagnosed with normal calcemic, your calcium level's on the higher end of normal. It's not going to be on the low end, right? It's either going to be fluctuating into the high range or on the higher end of normal. And then seeing that pair afterwards to confirm, okay, now the calcium is staying in normal range and the PTH is staying in normal range. If your calcium level is low, then your PTH would still be high because of that. So yeah, you have to check as a pair. You pretty much should never check PTH by itself, with the exception of that post-op lab where you're checking it in the recovery room, because it's going to respond way before the calcium does. Other times, you really don't ever want to check it on its own, because you can only interpret a PTH with a calcium level. You cannot look at a PTH level and know whether it's normal or not unless you know what the calcium level is. Okay. Oh, and Mary says, okay, it's high. Yeah. So, okay, back to Mary, who's had 2 operations, 3.5 glands taken out, and then another half taken out. It doesn't look like your lab's improved. That is tricky. Yeah, it suggests that, it also suggests maybe we're missing something. And honestly, you can see a high PTH level with, not with 11, that's pretty high. but you can see mildly elevated PTH levels also with FHH. Somebody needs to look at your case and again review everything, because you may also have a fifth parathyroid gland that hasn't been found. It could be that they just left a little too much in there, but it's starting to seem odd. Something seems off here. I wouldn't have another operation unless you have somebody really experienced reviewing your case first. Okay. Liz says, hi, Dr. Boone. I had surgery over a year ago. I feel much better, continue to improve. I'm needing to take 5 berry melts a day. Last PTH was 43.9, which is good. Calcium's now 9.1, which is a little bit on the lower end. Is it possible that I may need to take 5 berry melts a day forever? I did have a gastric sleeve in 2012, so maybe absorption issues. Yeah, I would. I think, the 9.1 may be your baseline. So there are people who are at 9.1, the low nines, and that's kind of where they settle. And that is especially true if you have some sort of absorption issues. Gastric sleeve shouldn't do it as much as a gastric bypass. However, anything that kind of messes with the stomach or the first part of the small intestine can affect absorption. And so I would say, yeah, I would probably stay on the 5 berry melts a day. It's not an excessive amount. It's 5 berry melts is 1250 milligrams of calcium. So it's not an excessive amount, not a dangerous amount. And if it's keeping your calcium at 9.1 in the nines, then I would stay on that for now. Yeah. But I'm glad to hear that you're feeling better and things are improving. Okay, Paula asks, how long do I stay on a daily calcium supplement? This is tricky, and I even with patients, in my instructions I don't say, because it varies from patient to patient. And it depends on your bones, really. So I'm going to look at it. If you're a young person and you have a normal bone density, or we presume you have normal bone density because you're 30, you're otherwise healthy, you haven't had this very long, we take out a parathyroid tumor, I recommend staying on calcium and vitamin D for 6 months. If you have bone loss, so you have osteopenia, you have osteoporosis, I recommend staying on calcium and vitamin D for longer, in addition to the other things you could take, like vitamin K2 and magnesium. But I recommend staying on it longer to help your bones replenish the calcium that has been lost. Now, for everyone, your bones may have lost some calcium, and so staying on the calcium and vitamin D for 6 months makes sense. If we know you have bone loss, I recommend staying on it longer. And it also depends on what your labs are. So if at 1 year, your calcium level is 9.0 and your PTH is trending on the higher end, then you need to be on a little more calcium, or you need to restart the calcium. So it really depends on kind of tracking your labs over time too. If 1 year out, your labs look perfect and you're not requiring any calcium and your bone density is normal, then by all means, don't take the supplements. You're fine. But it really depends on your bone density and what your labs look like. And some people just need to be on calcium long term to maintain a normal calcium level, and that's okay, especially if you have any absorption issue. Okay. Pam says, I'm a 60-year-old PCP ordered standard labs after I complained of feeling awful. Calcium was 10.4, which is high at 60 years old. 10 days later, she ordered the PTH, which came back today at 59. TSH was also elevated. Is it significant that my labs for calcium and PTH were not done on the same day? Okay, so I just mentioned, right, that I always check them on the same day, but a lot of times that doesn't happen. A week later, your calcium level was probably still high at that point. It would be good to have them together. So typically, if you're my patient, I would just get a calcium and PTH together, but given this story, it really looks like this is going to be primary hyperparathyroidism. I would just want to recheck it, especially if this is like the only calcium level we have for you and the only PTH level. I would just recheck them both together, make sure everything, is consistent. The TSH sounds like that's a separate issue. If your TSH is really elevated, sounds like you also have hypothyroidism, which can be treated with medication, but that's separate from the parathyroid. But the calcium of 10.4, PTH of 59 is definitely very suggestive. Okay. Okay. Rachel says, what is the realistic expectations for someone who's had the disease go miss their entire adult life, having the disease for over 20 years and then having surgery? I also have my bone-specific alk-phos tested in minus 6.0. So realistic expectations. So I did mention, your body had to deal with this for a long period of time. You had parathyroid disease. If you've had it for 10 years, for 20 years, your body has adjusted and likely had some damage from it over that time. However, people still feel better after surgery. Now, your recovery might be a little bit rougher. So I always warn people that the longer you've had this, the more of an adjustment it might be. So having it for 20 years, definitely you're probably going to feel that drop in calcium. You may not feel great. It may take a little longer for these symptoms to improve, but you can still have improvements, and it's still better for your body, for your bones. Having that PTH continually acting on the bones is still not good for them. So reversing that is going to be good for your bones and getting it back up. So yeah, you still see all the benefits even if you've let it go for 20 years. And interestingly, some people do okay with this, having it for many years. Okay. Nancy says, due to ongoing symptoms, especially constipation after a second surgery, I reached out to another surgeon. She recommends a metabolic bone unit by an endocrinologist. What is this? Meaning they're probably sending you to a bone specialist, I guess. I think the unit might be referring to a specialist who deals with metabolic bone disease like osteoporosis. That's probably it. Michelle says, I have a parathyroid nodule and I get a raspy voice occasionally. Can the nodule cause that? Probably not directly. So it's probably not like an effect of the nodule on the vocal cord or on the nerve. It may be reflux. So parathyroid disease, high calcium levels cause reflux, GERD, heartburn. Even if you don't feel the heartburn, you may have irritation back there, and that is often the cause of the raspy voice with parathyroid disease. Okay. Jocelyn says, I have hyperparathyroidism, tertiary hyperparathyroidism due to long-term renal calcium leak. If I get the PTH surgery, I'm worried that my kidneys will still leak calcium, and I'm wondering what medications options there are to ensure calcium absorption so I don't end up hypocalcemic. I've had problems with thiazides in the past, but it's possible that's because thiazide raised my blood calcium to 10.4. Okay, after surgery, I'm hoping that thiazides will be more tolerable. Is this so? So Jocelyn, I'm assuming if you had renal calcium leak, then what you had was kind of low calcium levels and rising PTH levels over time, because renal calcium leak causes secondary hyperparathyroidism, and then long-term secondary hyperparathyroidism can lead to tertiary hyperparathyroidism, where the parathyroid glands just don't turn off. And at that point, your calcium can even go into the high range, and the PTH still doesn't drop. So that's tertiary. It can happen from long-term renal calcium leak. Yes, if you treat this, you will still have renal calcium leak after surgery. If that is what you've had, then that will not go away with parathyroid surgery. And unfortunately, what will happen is, as with all cases of secondary and tertiary, if you don't correct the underlying issue, then you're not solving the problem, right? So you can get the PTH down by taking out parathyroid glands. But if the issue is renal calcium leak, where your kidneys are leaking calcium, you have to correct that. Thiazide diuretics are the standard treatment. If it was a problem before because it raised your calcium, then you will tolerate it afterwards, or you may tolerate it afterwards. And that's probably what you're going to need to do, is to take thiazide diuretics afterwards. There are other options with renal calcium leak, but they're not quite as good as thiazides, and it requires a pretty in-depth look at your 24-hour urine calcium and other factors in that, like your sodium levels and citrates, oxide, all of that. So before you can sort of do that, thiazides are kind of the easiest treatment. Okay. Mary Ann says, do you Do you recommend dietary calcium over supplements with bone loss? I'm 72 and worry about supplements. Okay, this is a whole other topic in itself, is kind of the safety of calcium. So calcium supplements largely are safe if you have a reason to take them. There were studies done a little over 10 years ago, I guess now, or 15 years. Oh, it's getting up there. But within the last 20 years, there were some studies that raised an alarm about calcium supplements, because when we looked at these large groups of people and people who were taking calcium supplements, especially women, usually postmenopausal, we did see this slight increase in heart attacks and strokes in people taking 1,000 milligrams of calcium as a supplement. Okay, what's wrong with that study? Well, what it was looking at was people without a reason for taking calcium. So these were not people who had low calcium. They weren't people who definitively had osteoporosis or had any issues with calcium absorption. That's not what we were looking at. We were looking at all comers, and some of them were given calcium supplements, some of them weren't. When you looked at the actual patients within that, a lot of them were already getting a lot of dietary calcium, so they weren't deficient. They didn't have abnormal calcium levels. They didn't have absorption issues. They didn't have bone loss. They didn't have all this other stuff. They were taking it just as a prophylaxis. So if you have no reason to take calcium supplements, then you shouldn't take them. But if you do have a reason, then you should take them. And that cardiac risk, actually, we see that with low calcium levels as well. So both low and high calcium, excessive calcium or not enough calcium, is associated with cardiac risk. So if your calcium level is on the lower end, it makes sense to take supplements to get it into the normal range. That will actually be safer for your heart than leaving it on the lower end. So Marianne, I don't know where your calcium level is, but are supplements dangerous? No, especially if you need them to get your calcium level to normal range. That's the safest thing for you to do. If you can get enough in your diet, that's great, but a lot of people can't. And if your calcium level is still on the low end, even with your regular diet, then taking supplements is safe. Okay. Denise says, can you answer my question? Oh, I'm trying to find it. It's kind of strange how it shows up. So Denise, actually I don't see your question. It's kind of weird how this shows up, honestly. It's every time it's kind of confusing. Let me scroll down for a little bit more and see if I can find it. No. Okay. Oh, what was it called? FHH. FHH is familial hypocalciuric hypercalcemia. You could just look up FHH. So, Denise, I can't find your question. I'm scrolling all the way through. I'm not sure how it disappeared. Yeah, I'm not sure. I apologize. If you put it in later, I will try to answer it. Okay. And yeah, so Marlene says, I'm 8 weeks out, feel better, but not sure if my symptoms have improved much, or are my symptoms side effects of my hormone blocker, a chemo pill. It's tricky. With all of these symptoms, a lot of times patients will ask about a specific symptom and say, is it going to get better after surgery? And if it's one of the classic ones, I can say, on average, most people do feel this symptom improve after surgery. For some of the weirder ones, then I say, well, I'm not sure. We may not really even know if it's due to this until after you get this surgery done, and we can follow up and find out. And that's frustrating, I know, but a lot of these symptoms, especially kind of weirder neurologic ones or weird non-specific symptoms, they can be due to a lot of things, and I can't guarantee that they're definitely all due to your parathyroid, but I can say, okay, we'll find out, because parathyroid surgery is going to benefit you in other ways. It may not benefit this symptom. Hopefully it does, but we may not know until after the operation. Okay. Oh, Denise. Okay, good. Thank you. You said, how long can we follow up with you post-surgery? Years, months? I have patients that follow up with me years after surgery. If I do your operation, I want to follow you very closely, especially in the first few weeks. So if you have issues, related to calcium or the operation, then I want you to come back to me right away. If it's months after or years after and you have a question about your calcium or your calcium changes, then I do want you to come back to me. One, because I know your case, I have notes on it. So you can always come back to me years later. And people do. So, Alice has MEN too. Oh, I can't remember what your question was. But MEN2 is, I don't think, yeah. Anyway, it's one of the genetic syndromes. Okay. Sorry, one more. Mickey says, do drugs like Ozempic and Zepbound have any impact on calcium levels before or after surgery? That's really interesting. I don't know. Right now, so what happens with these drugs right now is they kind of slow down the gastric emptying. So you end up getting things like reflux. Could it affect calcium absorption? It could. I haven't seen anything like that though. I have a fair number of patients now on these medications and haven't seen it, but we probably haven't followed this long enough to really know. It's only been pretty recently that we've had so many patients on these medications in the last couple of years. So it'll probably take a little more time to figure that out. If it really affects absorption. Okay, I think I got all the questions that I can see still, and we're right on time. So 7:04. Thank you everybody for joining, and if you do have more questions, you can always come in next month. I do try to also post these on YouTube, and I will address questions there too. It's actually easier to follow the questions on YouTube than it is on Facebook. For some reason, the way they organize them is just hard to see. Okay, so thank you everybody. Have a good evening, and I will see you next month.